Hi P2s, welcome back to the Immunology lecture, and this is the part 3 of hypersensitivity. So I'm doing this video instead of in my basement office, I'm doing it in my actual work office. For those of you who have been to my office, you know my office is messy. For those of you that have never been to my office, now you know my office is messy. Alright, anyway, my office is pretty bad shape at this point. This is the best shot that I could get. Without further talking, okay, let's go to the lecture.
Alright guys, welcome to part 3 of the hypersensitivity topic. Now in this part of the video we will continue to explore the detail of type 1 hypersensitivity. So we'll talk about some of the etiology. Okay, where is it coming from? Is it environment versus other factors? Okay, and we'll also look at some subtype of type 1, i.e. Inhale versus ingest versus touching something. Alright, so we will talk about those things in this part of the video. Alright, without further talking, let's go started. Alright. So, we first look at some of the inhaled allergens here. Now, this table shows the property of most antigens, okay, that can elicit a type 1 hypersensitivity. And they are usually small. Okay, inhaled things are usually small, otherwise you won't be able to inhale, right? It must be floating through the air. Usually they are soluble, but they in most cases they present in a dry particle form, okay, either from a plant, we're talking about pollens, or grass pollens, flower pollens, or from animals. Okay, remember the denders are the dried skin cells, okay, dried dead skins from your cats and dogs, and we can have those, fecal matters, okay, of dust mite, okay, those are all inhalable allergens. Okay, they are proteins and peptides, right? Because they are being presented and stimulate Th2 helper cells, okay, and then lead to generations of IgE antibodies. Okay, so those are all related. So they're mostly protein peptides, right? And low dose of these would favor this IL-4 activation when producing CD4 Th cells, Th2 cells. Okay. So, oh, sorry, the slide go backward. Let me see. Alright, so there has been some link or observations to genetic susceptibility to allergies. So in the U.S., there are seems to be more people having allergy. Well, so there is some type of a study linking to about up to 40% of people of Europe and North American in the Caucasian populations are more likely to have to make IgE in responses to common environmental antigens. So it appears to be that some type of a genetic link to it. And we call those people that are more susceptible, we have this term, okay, atopy. Okay, atopy means they are basically predispositions to allergy. They are more likely to have allergies than other people. So atopic people, we've seen that they have higher level of IgE and circulating eosinophil. Remember, normally these eosinophil are not circulating that much in the blood. So those are part of the factors involving in more likely to have these type of reactions. Right, now here is a label in terms of polymorphisms and all these. You don't need to memorize these things in great details. Alright, so we're going to talk about one of the most serious type of skin reactions that are commonly resulted by this medications. So and they could be very fatal. Now this type of allergy name is Stevens-Johnson syndrome. Okay, this is usually referring to a little bit more mild form of this allergic attack, and toxic epidermal necrosis, or TEN. Okay, this is SJS. Right, TN is more serious. Okay, the hallmark, or the serious case here is shown on this particular picture here. It can be very bad on the skin, as shown here. You can cells could be dying, so these can eventually lead to cell-mediated cytotoxicity, right, leading to apoptosis of skin cells or keratinocyte, and it can manifest pretty badly. So here are some of the breakdowns in terms of what type of a genetic predispositions people could have that lead to more easy development of SJS and TEN. Now here are just some of the examples. For example, in more of the some patients that have this allergic reactions to carbamazepine usually have this type of HLA-B 1502 type of allotype. Now on your version there may be a typo here, right? It's 1502, just referring to the table here. I think the earlier versions I typed 5801. Okay, scratch that and write down 1502 is the correct allele type. Alright, and for people taking allopurinol, okay, there are also a genetic linkage to why those people that have these type of reactions, and so does apicovir. So genotyping is recommended in certain population during drug administration. So, and what happened with these reactions, okay, if you are not knowing you have this type of a polymorphisms in your body and you take this drug, what happens what will happen usually during the first 2 weeks, the syndromes resembles an infections, and with kind of like fevers, aching, a cough, and then starting to develop some rash with blisters on your skins, and then starting to peel away from the dermis and easily rubbed off. Okay, so it really affecting your skin, and the severity is characterized by the percentage of skin that are being affected. Usually SJS, when we're talking about SJS, we're talking about less than 10% of surface area being affected, and when we talk about TEN, we are talking about more than 30% of skin being affected. So the effect really looks resemble a type of a severe burn in a sense. Okay. Alright, so what are we talking about? Is it nature or nurture? Why is that, or happening? Now, there are some genetic susceptibility, as we discussed earlier. Okay, so people that have in general have higher levels of IgE, alright, or different type of IgE receptor, maybe they bind even more tightly. Okay, we know they bind very tight, right? Those Fc epsilon receptors, and we could have even more tighter variations, or excess IL-4, IL-13 synthesis, right? What do those lead to? Those lead to more of the Th2 helper cell development and lead to more IgE. So they're all kind of linked together. Or a little bit more abnormal type of these MHC class 2 allele could be also the case. And another interesting factor could be environment. Okay, there seems to be higher prevalence of incidents in industrialized nations. That also tied into hygiene theory. Okay, if a person are not being exposed to allergens early on, it could be developing more severe allergic attacks. So there's some story behind those. Okay. Now, one of the story behind all that potentially the reasons is something have to do with parasite, okay, helminth, okay, parasite infections. Now, there has been some observations in tropical regions of the world, for example, like maybe in Jamaica or somewhere, okay. So in those places, allergies, it's not prevalent at all, okay. Even though here we are talking about allergy all the time, and people spending a lot of money in treating seasonal allergies, but in those places, it doesn't seem to be the case. Now, I would argue potentially because they have different plants. Yes, they do have different plants than places around here, but the other reason that it's potentially be more convincing is in tropical climates or regions, usually parasite infections is more of a problem, okay. It could be a endemic in some way, okay. It can affect a lot of people. People are living with parasites. Now, what happened with parasite? Now, tie back to some of those earlier knowledge. We always talk about basophils and eosinophils have role in parasitic infections, right? Now, here in the US, we don't think about parasitic infection that much, but in those places, those are a real thing. So when you are infected with a parasite, a worm, okay, living inside of your gut, now your body will start developing antibodies to specifically against this parasite, so parasite specific IgE, okay. Now, and you will have those in your circulations, and in addition to, there are some low level of non-specific IgE. Now remember, IgE is IgE, okay. When we talking about an antibody, what it's specific is at the tip, right? We went through this on exam. The bottom, the Fc regions, are not that variable at all, right? They are constant regions, okay. They are not varying. So a non-specific IgE versus a parasite-specific IgE essentially have the identical Fc regions, and these identical Fc regions will compete for binding of these Fc epsilon receptors on mast cells. So they are competing binding to those, and what happened is that once these parasitic specific IgE are binding to mast cells, what it will respond is to respond to parasite, binding instead of allergens that binds to those antibodies, and that's why people that with parasite infections and high level of those parasite-specific IgE rarely develop allergic diseases, okay. So also those T-cell responses are also other T-cell responses are also typically suppressed in those people with chronic parasitic infections. So that's a very interesting thing, I believe. Alright, moving on here, again, it is a summary table or preview table that lead to different type of site of allergen entry. So we tend to think a lot on just sniffing it in, okay, through your inhalations here. Alright, so through inhalations, allergic rhinitis, more chronically could lead to bronchial asthma. Alright, so we are quite familiar with these type of allergen exposures, okay. Insect bite can also be it. Some of the, injections, okay, can also be the case, and sometimes it would be systemic if you get injected by, for example, a venom or some sort, okay. That can also lead to type 1, right? Type 1 are usually pretty fast in a sense. Now we'll talk about each individual of those in greater detail in later slides. Alright, so again, there are hallmarks of physical effect that are coming from IgE mediated mast cell degranulations, and depending on different tissue type, you have different responses. Okay, airways usually relate to decreased diameter. Okay, bronchoconstrictions. Okay, that would be the term, and then increased mucus secretion, so leading to symptoms of having a lot of sputums and coughing. It can breathe very well, and blood vessels usually can lead to increased blood flow, increased permeability, so you have a little bit edema, inflammations, feeling warm. Is also a type of symptoms. On the ingestion side, GI, if you eat something that are not upsetting your stomach, the first reactions is to vomit. If it goes down deeper, the following thing is diarrhea. So those are pretty actually they're quite non-specific in a way. Alright, let's first look at inhaled allergens first. Okay, now here is a graph of showing you those people that have asthma, what type of breathing in response to allergens. So immediately the breathing would be dropped significantly upon antigen challenge, and it recovered. Okay, but over the time there are still a drop in this peak expiratory flow rate, so that lead to sustained release of leukotriene, prostaglandins, and induced mediators. So all these things lead to some of the bronchoconstrictions. Okay, limit your airway. Okay, and then that's why these values, the peak expiratory flow rate drops. Okay, you're not breathing as smoothly as you could. Okay, alright, so continue with inhaled allergens. Okay, we'll look at first, this is a little bit of mild, rhinitis. Okay, rhinitis, being there's inhaled antigens entering the mucosal, activate the mucosal mast cells locally, and then lead to release of the mediators, lead to increase vasal permeability and all these. Okay, increase mucus productions, and also lead to eosinophil chemotaxis and leading to activated eosinophil. Alright, so that is the initial stage, and symptomatically you have sneezing, runny nose. Those happen very quick, right? For mild one, those are usually self-limiting, usually last no longer lasting tissue damage. Okay, now how we accomplish that is part of the defense mechanism, right? We have mucus. Well, flushing out, okay, basically removing some of these allergens, you'll get better pretty quick. Now, what if these challenges? Okay, what if these allergens persist in the systems? Okay, it will eventually what happen is lead to more of a chronic conditions, allergic asthma. Okay, that would be the term. So the reactions really shifting from type 1 into type 4 bases. Okay, so in those cases there are more cell-mediated damage into those area, and also have significant increase in mucus chronically, and contract of your bronchial smooth muscle, so your airway is narrowed, and also there are increased vascular permeability that persist, leading to persistent infiltrations of Th2 cells, neutrophils, eosinophils, and all these. So, and eventually lead to more of the airway remodeling and damage that we see in the chronic patients. Alright, so here is a graph from the microscopy graph. Okay, just showing you different types of positions with a chronic asthma. Okay, so mucus plug, so you can see the mucus are significant. Like here on this B panel, this is a bronchial wall. Now, the lumen, it looks like it's, basically, narrowed in a way, and they're showing a lot of eosinophils, neutrophils, and lymphocyte infiltrating into those epithelium, and that also, leading to all the symptoms that we and remodeling we've been talking about. Right, so that's inhale. So we are happening, these things are happening in your airway. Now we look at the second type of the allergen sources that can also lead to type 1. Right, we're still talking about type 1, okay, at this point. Just a reminder. Right, so these are immediate, okay, having a little bit bump, okay, hive, okay, that coming up. Some people allergic to nickel metal, okay, NICKLE nickel metals, can, if you, in some old days, the people doing electroplating, okay, electroplating on perhaps some of your jewelry or on some of the glasses frame, okay, they contain some nickel. It really helped with the process. But unfortunately for those people that have allergy to nickels, it will react and, causing a little bit bump, itchiness, angioedema, okay, if you continue to, challenge yourself with that particular allergen there. So those are some of those symptoms you can observe with this contact hypersensitivity, and they may last about 30 minutes or so, depends. Alright, so here are some of the more specific dermal allergies. Okay, you perhaps have learned it in self-care, which I didn't really talk about much. Eczema, atopic dermatitis. Okay, so those are itchy skin rashes, and we don't really know why. Well, we know that those patients usually have higher IgE levels, and these atopic dermatitis are essentially chronic. Okay, they comes and goes, I feel like. Now, so my son have some mild form of eczema, very similar to what it shows in the picture, but not as serious on the back of his hand, and it comes and go. When it comes, we give him some prescription steroidal cream or ointment, and he put it on, gets better, and in a couple of weeks it comes back. Don't know what's the reason. Okay, we've been doing the same thing forever, and all these things, oftentimes they may resolve in adolescence, but I've known some people that have eczema cases that last until adulthood. I mean, actually, those people are older than me. But anyway, so it varies in a sense. Alright, so it can also be a ingested allergen. So here is a golden question. Okay, so did you notice what tie I was wearing at the beginning of the video? Alright, so no cheating, okay? No going back to the front, okay? You'll get to know it after this particular recording, alright? So ingested allergens, okay, we're talking about it could be many things, okay? I feel like these days many things, food allergies seems to be a real thing. Nuts, fruit, peanuts, fishes, shellfish, egg, and milk, just about all the common things that you can be. Right, so you ingest these type of a food, okay, these are all they all have protein components, okay. Ingest these, it break down by your stomach, intestines, okay, leading to basically breaking down into peptides, okay. Small peptides are perfect, okay, for activating the Th2 helper cells, okay. And the symptoms, okay, usually these vomiting and cramp in the initial stage, and if it get absorbed, it can actually lead to some of the more vasodilations. I've seen people faces get red after eating shellfishes, okay, and if it goes down further, well, it leads to diarrhea, okay, that well, I mean, vomiting and diarrhea, they're not specific, so sometimes they are a little bit hard to differentiate. Are they really getting a food poisoning versus a allergy? So you have to rely on some other symptoms in many cases. Okay. Alright, so there are more severe things. We're talking about systemic anaphylaxis, okay, caused by allergy that reach bloodstream, okay, and activate mast cell throughout the body. So this is systemic, okay. The whole body is having this, massive mast cells degranulations, okay. So what will happen? So it will degranulate, release a whole load of inflammatory mediators that lead to significant more severe symptoms that we've seen before. So if the airways mildly contract, now contract more, okay, difficult swallowing, difficult breathing, and have wheezing problems, and GI, even you lose more fluid in terms of throwing up and having diarrhea. Now there are more systematical circulation type of a problem affecting your heart and vascular system. So it will increase your capillary permeability, so you have swellings, including your tongue, okay, the tongue swelled, harder to talk, okay, and it can also lead to blood pressure drop and reduce oxygen. So all these symptoms are potentially fatal. So systemic anaphylaxis can be very serious in a sense. Alright, anaphylactic shocks. Okay, here is just a treatment example, EpiPen. Okay, so people or kids, a lot of time they have known severe allergy to a certain food item. They're often being instructed to bring a EpiPen, okay, along with them, epinephrine, so that to school, so that if anything happens, they can immediately inject these EpiPen to save their life. So what it does, it stimulates the reformation of tight junction between epithelial cells, okay, through the vascular smooth muscle contractions, okay. This alpha what? Alright. Anyway, so this alpha mediated alpha 1 here. Alright, so I didn't realize that was on there. Alpha 1, right? And peripheral constriction, so limiting the peripheral edema, then fluid loss, and maintain the blood pressure. It's okay. Remember, when you have anaphylactic shock, you have blood pressure drop, so you want to boost those. Okay. It also activate beta. Okay, beta agonist effect, and also promote smooth muscle relaxation in the bronchial, right, and stimulate the heart, okay, affect the heart. So all these, non-specific, they're non-specific, in general, we just want to reverse the effects that are caused by those inflammatory mediators. Alright, treating hypersensitivity here. Now I won't go into way too deep in terms of the treatments, okay, because that are a little bit overlapped with your PT modules, okay. So we talked about epinephrine briefly. You've learned about something about corticosteroid. Actually, you learn a lot more in the JAM module. NSAID we talked about in self-care, and you're gonna get another exposure of NSAID in the JAM module as well. Alright, and then antihistamine. So we talked about antihistamine. So these things are presented previously, so I'm not going to go into too much of a great details, and I'll talk about a little bit in the immunological standpoint of how to treat hypersensitivity. Now, just trace back a little bit. The best way is avoidance, right? If you are allergic to cookies, don't eat a cookie. That would be bad, right? So cookies are so delicious, but in general, avoidance, okay, it's something that to have to practice, if particularly with those people that have very, very, very serious anaphylactic attack resulting from allergies. Alright, so So here there are other non-pharmacological approach. Basically, we are talking about modulating the leukotriene pathway from the arachidonic acid breakdown. So I won't talk about these things, okay, here. Right, so you will learn those in your PT module here, particularly your pulmonary module. So I'll skip that. Just be aware that those are the pathway, those are the targets, or those are the pathway that can be mediated. And also you can also use antibodies. If you can use anti-IgE antibody if IgE is the bad guy, well, let's block it. Right, so that's the idea of a lot of these antibody drugs. Alright, so immunological standpoint in terms of the treatment, first we can have utilizing the principles of desensitization by giving allergy shots. Okay, allergy shots are actually injecting with a particular type of allergens. Okay, usually go from a slow dose and slowly go to a high dose. Now really the exact mechanisms it's unknown, okay, but it have risk. Sometimes low dose can the first dose could induce anaphylaxis. Okay, so it had to be administered in the physician's office so that they can see if you are reacting to a very, very low dose there. But now the exact mechanism is unknown, but it's believed that it's making a shift from IgE to IgG4. Okay, so as long as we're not having IgE, okay, they're not binding to mast cells, okay, then they can lead to less severe of allergic reactions. Alright, so the other things could in terms of desensitization is by giving vaccinations of a small peptide, alright, that is derived from the bigger piece of allergens. Okay, so there are smaller piece essentially should have no risk of anaphylaxis, okay, and presented by the MHC class 2 and to the CD4 Th2. So the strategy is really to induce energy. Okay, energy means a state of unresponsiveness to an allergen specific T cell. So they are really trying to make them to be a little bit non-reactive to the particular allergen there. Alright, so it's been long. I've been talking for about 33 minutes or so, and it is time to take a small break by doing some questions. Alright. Well, it is time for Who Wants to Be a Millionaire again. Again, no one can be a millionaire by answering this question, but I think it will help you learn the material. That's why I'm doing it. If you don't think you want this portion of the material, you can definitely skip it, but I highly encourage you stick with it. Okay, let's start the questions. Okay, last time we went through the $500 questions, and we will be moving to the $1,000 questions. Okay, all right, so what is the questions for this $1,000 question? All right, which of the following promote isotype switching to IgE? A, IL-2, B, IL-4, C, IL-10, and D, TNF-alpha. Alright, I'll give you 5 seconds to think about it. 1, 2, 3, 4, 5. Do you have an answer yet? Now, if you've been paying attention for the past 33 minutes or so, you should know the answer. Alright, the final answer is IL-4. You got it. Those of you who don't get it, sorry, but anyway, it's not meant to be tricky, these questions, so basically they're just a quick recap of what we just went through for the past 30 minutes. Alright, so let's move on to the next level. How about that? Okay, that's the $2,000 questions. Alright, it's getting high stake. Is it gonna be more difficult? Well, it could be, but these type of quick questions, it cannot be too difficult in my opinion. Alright, allergy shots. Okay, it's asking you about allergy shots. I went through it, okay, in the last couple minutes. And how does it work? Inducing IL-10, inducing TNF alpha, inducing IL-2, and inducing IgG. Alright, so I'll give you 10 seconds to think about it, maybe flip through the slides and things like that nature to look for the answer. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Well, I don't know if you guys could be watching with others. Okay, you're probably watching this alone. Okay. Anyway, the answer. Do you have an answer yet? Shout it out. Or this one. Now you may think about this. Well, the exact mechanism may be unknown. Okay, but there is a potential explanations which we just went through on the page. Alright, what is the final answer? Did I hear that? Alright, so it is D, inducing IgG. Alright, you got the 2,000 questions, I hope. Okay, that's awesome job.
So, to wrap up this part of the lecture, I asked you in the middle of the lecture of, hey, what tie am I wearing? Ta-da! This is sushi tie. So, a lot of people are allergic to seafood, potentially allergic to many of type of the sushis, okay? But anyway, so this is to wrap up part 3 of hypersensitivity. There will be one more part 4 of hypersensitivity coming up, okay? So that's it for today, or that's it for this part, and I will see you in the next video.